These are my financial disclosures. And I'll start by saying that more is not always better. You can see this ad. It corresponds to a campaign that was launched by a Canadian initiative in a university, trying to educate and promoting the idea that, as it is in life, more is not always better. And how is it possible that more is not always better and that it can actually be worse? I encourage you to read this letter from Enya Tolonen, in which they actually discuss the different reasons why this happens. There are cultural and legal environments that exert pressure to do more. Some data are often rejected or ignored, especially when they say that some tests are not useful. There are always new technologies and frequent testing that when this happens, we have more diagnosis in a way that sometimes even disease is so subtle that we are not sure if the patient has the disease or not. There are also harms of diseases and pseudo-diseases that are discounted or ignored. And some efforts of the research actually are going into missing some level of analysis, which is the system global idea. Still today, there's uncertainty in medicine, although it is evidence-based. And there is also a market atmosphere that actually is part of this reason why sometimes doing more is not always the best thing to do. How does the EGS has addressed this problem in glaucoma? In the new EGS guidelines, there's actually a new section that's called Things to Avoid, Choosing Wisely. This was done after an evidence synthesis that was in two different meetings performed by EGS members in collaborations with Cochrane US. At the end, 12 recommendations were developed, and we have these 12 key evidence-based messages that I will try to summarize to you now. The first one is about corneal thickness and its use in adjusting IOP. So the EGS recommends to avoid these correction algorithms because they are not validated, and we should therefore not use them in our everyday practice because they actually lead to more errors. There are reports showing that when you do this, you can have even 40% of the time a mistake. The second key message is that SWAP, short wavelength automated perimetry, it has shown no evidence of better performance than regular white-on-white perimetry, so it does not have a role in current clinical practice. It actually brings more noise to the system, and it has a high variability and a larger curve for learning into the patient. The third commandment is about OCT. And glaucoma progression and diagnosis based only on OCT should be avoided because OCT on its own, without other data or other clinical information, is not able to provide a robust diagnosis of glaucoma. It just gives us a statistical deviation from a reference database. So it's a tool to help us diagnose, but it cannot diagnose on its own. The fourth message corresponds to cap-to-dis ratio. Because there are big differences in size and shape between even normal population, it's not useful to use or base our decisions of diagnosis only on CDR. And even more important, the assessment of CDR is very variable, even among experts. So it is not recommended to use it on its own for diagnosis of glaucoma or even to detect progression. The fifth key message is about angle imaging, and although anterior chamber angle has shown some use, it cannot replace gonioscopy, and we should do gonioscopy in our patients to detect properly angle closure because the accuracy of anterior segment imaging testing is suboptimal, and we cannot actually see small synechia or pigmentation. The sixth message corresponds to routine genetic testing and direct-to-consumer phenotyping. It is not recommended to offer genetic tests to all glaucoma patients. We should only do it in those patients that have high risk, and online home testing kits are unreliable, and we should not use it in our patients to guide diagnosis or treatment. Number 7 is about AI. And although AI is a very useful tool that will come more and more in the following years, they will support our decisions, but AI is not able to replace clinical judgment. So we should not base our decisions only on AI. Number 8 is for provocative test angle closure, and we should not use it because a negative test does not exclude actually angle closure, and a positive test does not always represent real life circumstances. So it may be that we do this test and actually our patient does not need the treatment in real life. Intervention for blind, painless eyes with very high IOP are not recommended. And once vision is lost, it's only useful to do further treatment if there is pain related to this high IOP. Laser trabeculoplasty has shown no evidence in juvenile glaucoma, although it's an open angle glaucoma. There's no evidence for this particular type of glaucoma. Number 11 is for carbonic inhibitors and hyperosmotic treatment in patients with sickle cell disease that should be avoided because we can cause an acute hemolytic crisis. And the last key message is for lowering IOP to just below 21 in those patients that have an advanced glaucoma, because in these patients, low IOP, even in the teens, may be needed. So the take-home messages: we have learned that more is not always better, that there are several barriers to change practices that need to be taken into account, and that the EGS have 12 recommendations to help us choosing wisely. Thank you very much for your attention.